Welcome to the Sports Docs podcast. On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan. On today's episode, we're focusing on plantar fasciitis with Dr. Arianna Gianakos, an orthopedic foot and ankle surgeon at the Yale School of Medicine. We have some great articles for you that contribute well to our conversation on plantar fasciitis. As always, links to all the papers that we discussed today on the show can be found on our podcast website, www.thesportsdocspod.com.
We start off our discussion today with an article from the May 2021 issue of Sports Health titled Risk Factors for Plantar Fasciitis in Physically Active Individuals. This systematic review and meta-analysis found that increased ankle plantar flexion range of motion, higher BMI, and greater body mass were the only significant and consistent risk factors associated with plantar fasciitis. The authors determined this was likely due to increased mechanical load and strain on the plantar fascia. In contrast, factors often thought to contribute, such as arch height, static pronation, ankle dorsiflexion, training volume, height, and Q angle, were not found to be statistically significant.
Then, from the October 2019 issue of JAOS, we discuss an article titled A Prospective Randomized Controlled Trial Comparing Physical Therapy with Independent Home Stretching for Plantar Fasciitis. Dr. Chris Chiodo and his team at the Brigham and Women's Hospital in Boston found that both groups demonstrated significant improvements in pain, function, and overall health as early as 6 weeks, with continued gains through 12 months. Importantly, there were no statistically significant differences between physical therapy and home stretching at any time point, indicating that a structured home-based plantar fascia-specific stretching program may be just as effective as supervised PT for most patients.
We are joined today by Dr. Arianna Gianakos, an orthopedic surgeon specializing in sports-related injuries of the foot and ankle and assistant professor of orthopedics at the Yale School of Medicine. She is also one of the founding members and president of Speak Up Ortho, an organization that aims to improve the culture in orthopedic surgery to foster diversity and inclusivity. Dr. Gianakos is an avid researcher and has authored over 85 peer-reviewed publications and more than 100 national and international presentations, particularly on sports-related foot and ankle injuries, so we're very excited to have her join us today for this discussion.
Plantar fasciitis is one of the most common causes of heel pain. The revolutionary and innovative solution from push braces focuses on actually relieving this strain. The taping concept focuses on effectively relieving the plantar fascia by helping it to support the arch. Push Foot Brace FP directly alleviates pain, allows you to recover and to move freely at the same time.
The best way to understand the difference is to wear one. Email samples@bracelab.com and mention the Sports Docs for a free brace sample. Explore the full line at bracelab.com. Are you still spending valuable OR time prepping grafts? If so, you should take a look at what JRF Ortho is doing with pre-sutured tendons. They actually offer one of the most comprehensive portfolios out there, covering everything from ACL to PCL, Achilles, and even AC joint procedures. One option getting a lot of attention right now is the SpeedGraft Quad Link. It's designed for all inside ACL reconstruction with consistent sizing, 64 to 72 millimeters in length and 9 to 11 millimeters in diameter, so you know exactly what you're getting every time. And JRF Ortho is the only provider offering a pre-sutured BTB, the pilot graft, giving you even more flexibility depending on your technique and preference.
The big advantage here, efficiency and consistency. No autograft recovery, no graft prep, no construct assembly. Just a ready-to-implant solution that helps reduce OR time and eliminates donor site morbidity while delivering reliable, high-quality grafts. JRF Ortho has distributed over 30,000 allografts worldwide, and their focus is simple: providing high-quality allografts to surgeons so they can improve the quality of life of their patients. If you haven't explored pre-suture tendons yet, this is definitely worth a look. Visit jrfortho.org to learn more. JRF Ortho, 20 years of excellence in motion. Well, welcome to the show today, Arianna. Thank you so much for taking time out of your very busy schedule to be here.
Thank you for having me today.
Yeah, we're excited.
So today we're talking about plantar fasciitis, which is a very common and often frustrating condition for our patients, really of all ages, but especially our athletes as well. Now, before we dive into treatment options, we want to start at the beginning with the underlying pathoanatomy. So first, what is plantar fasciitis? Like, what is happening structurally?
Yeah, so this is a very common injury that we see in the general population, especially in our athletes, though, especially in our runners. This is typically where patients come in and they're really describing this sharp stabbing heel pain, particularly on the inside of the heel. And this is prominent because this is where the plantar fascia, which is this band that spans the bottom of the foot, actually inserts into that heel bone. And what can happen is over time, just from wear and tear and overuse, there's pulling and stretching of that band, and it can cause small little tears, micro tears, as well as inflammation that can cause persistent symptoms and pain and doesn't always go away on its own. And this can be quite debilitating for a lot of people who are super active and really can't stand without significant pain.
Yeah, for sure. And Ashley and I, this isn't, we're not foot and ankle surgeons like you, so we're not seeing a lot of this in our day to day. So, refresh for us, you talked about they'll present with heel pain. Like, what are some other things that they come in complaining of?
Yeah, typically what'll happen is when patients wake up in the morning, they'll take one step, and that first step, they'll feel this sharp, excruciating pain right in the heel. Then sometimes if they walk it out a little bit, this can calm down for them. Oftentimes, if they start ramping up activity, though, they feel this stretching type of pain that can go throughout the arch of their foot. This can also cause a lot of problems with walking up and down stairs, jumping, running, and all those types of exercises. In addition, some people can often complain of tight calves too, and a tight Achilles tendon, and that can all be related to issues with the bottom of the foot. One thing to keep in mind is, we see this especially in our female patients, where we found now, based on a lot of different studies, that hormones can also contribute to changes in foot structure, especially in the padding of the foot. And so patients come in with not only heel pain as a result of insertional plantar fasciitis, which is that inflammation we just talked about, but also what we call heel pad atrophy, which is where we actually lose a lot of the fat pad in the heel. And that's where the pain is spanning not just on that inside of the heel, but throughout the entire heel. And you can actually have both things going on at the same time. And this can be really debilitating for patients.
I didn't know that. I didn't know the hormonal side.
Yeah. We want to lose fat elsewhere. Of course, we're losing it in our heel, which is not fun.
I was just going to ask, is that like that perimenopausal, like hormone drop that we're seeing, like that causes frozen shoulder? Is it the same timeline, or is the same for individuals?
Yeah, no, it's actually exactly corresponds with that. So as we are getting a little older in that perimenopause to menopause stage, your estrogen levels are fluctuating. And this can actually cause a diminish in the fat pad, in the actual heel pad, and also in the base of the forefoot, which is where what we call metatarsalgia. So some patients present with pain at the forefoot. So when they're trying to push off to run, they get pain in the forefoot, but then also in the heel. And a lot of the times when estrogen is dropping, you end up losing a lot of the fat there. And this can also fluctuate though. And we see this in a little bit older individuals who see hormonal regulations during their menstrual cycle. This can actually fluctuate as well, where sometimes they're getting more heel pain when the estrogen levels are a little higher. So really interesting and still something new we're exploring, but I definitely think it's all related.
Oh, that's really interesting. Another thing my perimenopausal patients are going to hate when I tell them it's linked to hormones, just like frozen shoulder. So you did a really nice overview of some things to look out for, like symptom wise, but what are you looking for on exam? So like, what's like your go-to maneuver that's like you go to see if there's plantar fasciitis present?
Yeah. So initially I'll have patients try to stand, and a lot of the times they can't stand on any kind of hard floor, just because there's not enough cushion in that heel pad area. So they have sharp, excruciating pain just with standing alone. On physical exam though, we actually palpate the plantar fascia insertion point and also the plantar fascia band into the arch of the foot. A lot of people have the worst tenderness right in the insertion, which is really on that medial inside aspect of the heel. Although this can radiate into the rest of the heel and into the arch itself. So patients can also complain of pain when they're actually scrunching their toes and moving the foot, and when they're putting pressure on the foot and standing and the arch collapses a little bit, that can cause a lot of extra pressure into the plantar fascia. And then once again, we often see calf tightness at the same time. So we're testing the range of motion at the ankle and seeing if this is tight as well.
Okay. And then is it a role for imaging? I don't remember much about learning much about that. Are you going to get an x-ray and an MRI? And if so, what are you looking for in those things?
Oftentimes we'll start with an x-ray just to make sure there's no other concerning cause for the heel pain, potentially a little fracture in the heel bone itself, although oftentimes you need further imaging to really assess that. The x-ray does show us, though, if there is an associated plantar calcaneal spur. So essentially that's an extra piece of bone that oftentimes we'll see because of the pulling of the plantar fascia band at the insertion point. Now, I will say, though, a lot of people get hung up on, I have a huge spur, so I obviously have severe plantar fasciitis. I need to get rid of this spur. But I've seen patients who have really bad symptoms and no spur, and then other patients who have huge spurs and no symptoms whatsoever. So the spur is there. It can indicate that you have some irritation in that area, but that's not really the defining factor. But the first image we get is usually an x-ray, and then we usually start with conservative intervention first before proceeding on getting further imaging, unless there's some other concomitant injury we're worried about.
Okay. Makes sense.
That's great. So before we talk about treatment, that's going to be a lot of our discussion today. We want to talk a little bit about risk factors, why does this occur, particularly in active individuals. So our first paper looked at specifically risk factors for athletically active individuals developing plantar fasciitis. And some of the findings were expected, while other findings that we may historically have thought contributed were found not to be significant. So let's start big picture. What are the classic risk factors for plantar fasciitis? And did the results of this paper surprise you?
Yeah, I think that this paper was a well-written study. I don't think I was super surprised with a lot of the findings. I think it's really hard to really pinpoint what is a true risk factor for heel pain and for those who maybe have it ranging from just a couple days where they have an episode of inflammation to the more chronic plantar fasciitis patients that we have, which is really debilitating for months on end. And these are the patients we get really worried about and that usually need to try a couple different conservative interventions to really overcome this. One thing we do see, though, that I'm not even sure was mentioned is the arch height. If patients have flatter feet, so if you're noticing your arch is starting to collapse, which once again, as we get a little older, wear and tear, the post-tib tendon, which is one of the main tendons for push off and walking and for arch support, that can get overused and that can cause your arch to collapse a little bit. And by that arch collapsing, you're actually putting more pressure on the middle part of the foot, which is causing more pressure on the plantar fascia area. Another thing is if you don't have a ton of motion, which that was addressed in the article, and if you're tight where your foot is really scrunched up almost like you're a ballerina and you're pointing your toe down, and if your foot is in that structure for longer periods of time or your Achilles is really tight, then anytime you go to stand, it's going to stretch that band and can cause a lot of inflammation. Another thing that was not surprising was BMI, which is body mass index. And this is just basically demonstrating that the heavier we are and the more load that goes through that heel can also cause increased pain. And then just to touch on what we said before, I do think there's a lot of hormone imbalances that can contribute this. And us as women, we unfortunately see this a lot more often than our male counterparts sometimes, and it can linger a little longer too.
Yeah, I think that's super helpful. I actually kind of forget about the posterior tib, as far as its relation to that. And is that, so remind me because recalling back, talk to me about the BMI and the posterior tib. Is that related or no?
The posterior tib with the plantar fascia? Yeah. So I do think, the foot is such an interesting, anatomic joint, well, multiple joints actually. And I think unlike, you think of your hip, it's a ball and socket joint, your shoulder, ball and socket, knee is a hinge. The foot and ankle, there's so many bones, so many joints, so many ligaments and tendons, and it's so complex. So there's many degrees of freedom with the motion. And also we're constantly on it. We're putting all of our load through this. And so the post-tib tendon is one of the main tendons. It comes from more the inside of the leg and it wraps down around the back back of the inside part of the ankle, and it inserts right into the midfoot. And that is the most important tendon for controlling the arch height. So it is definitely related to the plantar fascia, which also helps control some of the arch height. So we do see that these two can coincide together. And oftentimes patients will have pain in the heel on the inside where that plantar fascia inserts, but they'll also get posterior tibial tendonitis where they get inflammation of the tendon. And all of this is from overuse. And you can imagine in our runners, especially those who might have a little flatter feet, they're constantly pounding, and especially the long distance runners, and they're putting all this pressure on that inside of the plantar fascia, the post tib, and that can really inflame that whole area, causing push off and running and landing really difficult.
Okay. That makes sense. Thank you. You had to bring me back a little bit. But we want to start to, like, now that we have a good grasp of those like underlying risk factors, we do want to start to dive into treatment, which is obviously what we all get very excited about. So let's start with night splints. We all hear about them all the time. Those are sort of the things that I think first pop up for people when they start to Google and learn about what's going on with them. That's what kind of comes up. But, do you feel like they work for patients? Do you recommend them? What are your thoughts on the night splints?
Yeah, so something I tell all of my patients when it comes to heel pain and plantar fasciitis is that I do not believe there is a one size fits all treatment. I actually tend to sit down with patients and I, say I have a toolbox of a bunch of different things that we can do to try to help alleviate your symptoms. And that what works for me or works for, my colleague may not work for them. It may not work for their mom, and that it might be a little bit of trial and error. And I really try to make that an expectation because it's really the truth. That sometimes little things work, whereas other things don't for other people. Everyone's different. Plantar fasciitis is like a snowflake injury. There's not one that's the same as the other. When it comes to night splints, that is something that we can definitely try and we utilize, particularly in patients who really truly come in saying the first step in the morning is the worst. Or when I've been laying down for an extended period of time, it's that positional change from being sleeping in my bed to standing. And the reason why this happens is if you think about just the foot position when you're sleeping, your leg is straight out and the foot is at rest. So your ankle is planted downward, like that ballet position that we talked about before. So then that foot is really cramped up. And so that plantar fascia is really tight. And then you go to stand and it pulls and tugs. So if you're sleeping in a night splint that holds the position of the ankle in a 90-degree angle, that's causing that position of the plantar fascia to be at a stretched length the entire night. So you're not going from a scrunched up position to a stretched out position really quickly. And that can help calm some of these symptoms down. So it is something we often utilize, particularly though, if those patients are coming in saying it's actually worse in the morning, but it does get better as I'm walking on it. Patients can do very well with a night splint for a short period of time.
Makes sense.
That's great. So that's very helpful for nighttime, but what about daytime wear? So there's a lot of orthotics on the market, and my patients will mention them a lot. There's heel lifts and heel cups and arch supports and AFOs. So do you recommend the use of any of these orthotic devices? You mentioned that toolbox. Are there a couple that are your go-to for daytime wear?
Yeah, something really simple to try initially are heel cups. I like silicone heel cups because they do give extra cushion. And one thing I tell my patients, because there is some of this overlap between plantar fasciitis and heel pad atrophy, is that this is a cushion problem as well as an inflammation problem. So, walking on hard wood floors or walking barefoot, I don't recommend during this time frame when you're trying to heal this. So anything cushioned. So getting a well-supported sneaker that has extra cushion in the heel, that's going to be super helpful for you. Heel cups, which are the silicone heel cups that can go right into your shoe, that can give you a little bit of provided cushion. Once again, as we talked about, you could have potentially a flatter foot, so the arches are collapsing. So sometimes getting a medial arch support that has some good cushion within the heel, that can also help you, because I always say our foot's like a tripod. So if you think about it, the big toe represents your pointer finger, the small toe represents a middle finger, and then your heel represents your thumb. And if you're standing in a tripod, if you're collapsing that arch downward, then your tripod is off. So that's going to fall over. You're not going to have good biomechanics when you're walking. It's going to affect your ankle, your knee, your hip. So getting some arch support to correct that so your alignment is maintained is also going to offload the plantar fascia. And then there are a bunch of different over-the-counter braces. I know Brace Lab has a really great arch support that wraps around the bottom of the foot and actually supports the arch. This is something that can be very comfortable and can sneak right into a sneaker as well. So once again, it's one of those, it is a little bit of trial and error, but it's really finding what works for you and knowing that this is not something that usually resolves within a couple days. This is more a couple weeks to even a couple months before heel pain can really calm down usually.
Yeah, I love that. I think you're so right. Like we have to sort of individualize treatments to patients, and they'll, what works for one person doesn't always work for another. And, it sounds like you do a great job with your patients trying to individually prescribe and find the thing that works best for them. And I think that's great. We briefly started to talk about orthotics and medial support. And how much do you think people actually are fine with prefabricated versus getting something custom? Like, I don't have a good sense of that when people ask me, do I need to go get custom orthotics? Like, what percent of people, if there is a percentage, need that? Or is off the shelf great for them, for most?
Typically, unless someone has a really severe deformity or arch collapse, or where they have some other ankle issues, or, their alignment's really not able to be maintained, I usually try over the counter first. I think that unfortunately, a lot of the custom orthotics can be very variable depending on who's doing them, where you go for them, are you good at communicating with the person who's creating the orthotics? And some people just don't like the rigidity of them. So I typically try to start with over the counter first, as well as shoe wear modifications, because these are something that are often more cost effective as well. And just finding, appropriate sneakers that, if you need a wider toe box because maybe you have a bunion too on top of this, or maybe you need more cushion in the heel, or maybe you have some midfoot arthritis with that arch collapse. So getting a shoe that's more rigid sole where you can't really flex through the toe box, so you're not putting so much pressure through the midfoot joints. Those are all things that can really help, and they're subtle, and they're things that are just, once again, you walk into a sneaker store, see what's comfortable for you. With regards to over-the-counter orthotics, I do try those first. There's a variety of different companies and brands, not a one size fits all, but I do like ones that are more cushioned, not too rigid. They're made out of, some of the same materials that your insole of your shoe is made out of, versus sometimes you even get like that Tempur-Pedic feel, the foamier ones. Patients tend to like those because they're not so rigid and they're easier to progress. And then if you need more, and sometimes the patients come in saying, you know what, this worked, but I think I need more. That's when I'll then ramp up a little bit and say, okay, why don't we have a consultation with an orthotist to see if this is something that's a good fit for you.
Makes sense.
That's a great overview of the different bracing options. And I think, like you and Catherine summarized as well, too, I think it's not a one size fits all. It's a different approach and trial and error. I think a lot of times our patients aren't patient. So thank you for that. So now let's transition to another part of conservative treatment for plantar fasciitis, and that's therapeutic exercises. So our third paper compared formal PT to a structured home-based stretching program for the treatment of plantar fasciitis and found no difference in patient outcomes between the groups, including pain relief and function. But honestly, from a sports perspective, we've seen that before. No difference in PT versus home, and I still send patients to PT. So what's your opinion on this? Do you recommend supervised PT, or do you really think home stretching is sufficient?
Yeah, this is a neat paper. I like that it gives us the option of trialing home PT as an option. There's a lot of times our patients do come in and they're just like, look, I work really long hours. I can't get to physical therapy. I have a bunch of kids to take care of at home. I'm doing all this travel. So at times home PT might be the only option for some patients. So I think knowing that we can provide them with some exercises to do to help alleviate some of these symptoms is helpful. Oftentimes I tell patients to start with getting a tennis ball, putting it under the bottom of their foot and really rolling out the arch. Sometimes patients like a little bit of coolness to that. So I'll tell them to freeze a water bottle and do the same thing. And then actually I had a bout of plantar fasciitis back in the day when I was very active as an athlete. And I remember I would get some lotion and actually put it on my knuckles and gently just massage that heel area out into the arch. Stretching the calves are really important so that your Achilles is not too tight. So those are things you can start with at home. Although I think because this is more of a soft tissue issue. When I have patients who have this, I find hands-on work is really important. And so when you go to a physical therapist, they can do a lot of soft tissue massage in the calf, in the gastroc muscles, the soleus muscles. These are muscles that get very tight and can contribute to the heel pain. They can actually use their hands to massage the plantar fascia and the rest of the forefoot so that your mechanics are a little bit better when you're walking. Oftentimes I'll tell patients that they can supplement this with, if they have the ability to go for a massage and to focus on lower extremity work, a massage therapist can be very helpful to supplement this as well. But I do tend to recommend, if it's possible, to go to physical therapy. I just think you get a lot more out of it, and you do get some more individualized treatment. And at the same time, you'll be able to strengthen the foot muscles as well as help stabilize your ankle, which can all contribute to better mechanics when you're running.
Yeah, I think that, it's great. And as you said, not everybody can make the time, but there's other things that they can do. And you sort of already indicated like more proximal, at the calf. And I'm curious to hear your thoughts on like if you're seeing your patients have good success, if they do other sort of modalities, whether it's like dry needling or shockwave, in addition to the manual therapy. Like, do you see any benefit to these things?
I do. I think dry needling can be helpful, particularly if you do have tighter calves. I think that's where that really comes into play. For patients who are super mobile and maybe are, stretched out enough, I'm not sure if it's going to give them as much benefit, but if you're really tight, that can actually help loosen up that area so that you have more mobility at the ankle and in the foot. I actually have a shockwave machine in my practice. And so I utilize this for a lot of soft tissue injuries, plantar fasciitis and heel pain being one of them. I think there is good evidence to support that it can help. The way that shockwave works is that it helps reduce inflammation in the region. It helps promote neovascularization, so enhances blood flow, so all the good stuff can get to that region to start healing it. And it works on nociceptors, which are your pain receptors, to help really down-regulate that so it's not as painful for patients. And I do try to supplement that. And I see this a lot, my marathon runners in particular, or a lot of my athletes who are doing physical therapy and trying to get back quicker, they'll often use this as an alternate strategy to supplement that. And some physical therapy places actually have this in their programs, which is really helpful because sometimes insurance doesn't always cover this modality, which is frustrating sometimes. But I do think it's something that when it comes to soft tissue injuries can be very beneficial. And for us, if there's any way to reduce the need for surgery, this is something that patients can try and often can see good benefit from.
Ashley, do you know what this makes me think of?
What?
Are you remembering back when we were residents? We did an article for the Yellow Journal, like for JOS, on therapeutic modalities, but we tried them on each other.
Yes, we were the models.
Like,
a picture of me, someone was stressed. I like how Catherine was like, I'm the senior resident, so you're going to be doing all these things.
I'm just going to hook you up to this machine. It's fine.
That was great. That was good times. All right. So one last question for you, because you talked a lot about stretching, great exercises. I love this. Like if my patients come in, because you're not wrong. Like patients do say like, I work long hours. My kids have sports. I can't make it on the weekend. So like, these are some great exercises for them to do. And you mentioned a lot of stretching, but what about strengthening? Like I hear all about stretching for plantar fasciitis, but are there any strengthening exercises that patients should be doing?
Yeah, I think one thing that you can have patients do, there's not a ton when it comes to the arch support and the plantar fascia region. But I think working on the intrinsic muscles on the foot, which is the small muscles in the foot, can be very helpful. So oftentimes I'll have patients put a towel on the floor and put their foot down on top of the towel and try to scrunch the towel with their toes. And I have them do that a couple times in a row and then take a break and do that again. And that can actually help strengthen the arch of the foot and the intrinsics. I do think if they can also get either some sort of band or use a towel to do ankle range of motion exercises, particularly inversion, which is where you're pulling the foot inward toward the body, that can help strengthen your post-tib tendon, which is also important and for arch and push off. So I think those are things that they can incorporate in when it comes to more of a strength exercise. And then lastly, Achilles tendon raises, heel raises, where you can either do them from a standing position on the floor, or you can gently go to a stair and drop the heel a little lower. That can help stretch out the Achilles tendon. And then also you can push off with that, so that helps with strength as well. I think these are things that can be helpful, but once again, it's the combination of these stretches, these strengthening exercises, wearing appropriate shoe wear, maybe getting a heel cup, maybe getting, shockwave, or doing one of these other treatment modalities that can be helpful.
Absolutely. On the next episode, we'll continue our conversation with Dr. Arianna Gianakos and shift our focus to injection options for plantar fasciitis, as well as surgical treatment for recalcitrant cases. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportstalkspod@gmail.com or find us on Instagram at thesportstalkspod. We love your feedback.